Hello, my name is Pranav, and I'm part of the Health Needs RX Spotlight team. We are a new organization with a mission to empower people to make their own healthcare decisions. We create video content, information guides on essential topics like chronic disease, mental health, respiratory illness, health literacy, and more to help people optimize their health. Today, I'm joined with Dr. Annie Tedga, a pediatric cardiologist who will talk more about heart health. Thank you so much for joining us today.
Thank you for having me.
So how did you know that you wanted to become a pediatric cardiologist?
That's a really good question. It just happened when I was back home. I am originally from Cameroon, and I graduated from med school in 2012. It happened a long time ago. I graduated from med school, and then I went home and worked there as a general practitioner for 3 years. While I was in the hospital, like the main children's hospital back home, I ran into a lot of kids with congenital heart disease. And that's what sparked my interest, because we don't really get a lot of exposure to heart disease in med school. And I was just intrigued by the physiology, the pathophysiology really, and the limitations in our healthcare system to address them. There was actually a system in place that provided some kind of funding to fly them out to either Europe or the US for them to have the surgery. So it grew on from there. And then I came to the US and I completed my residency in pediatrics. And I knew during that time that I wanted to for sure sort that career and just get more involved, not only for kids back home who didn't have much options in terms of management, but even here in the US where there are areas where detection rates are still pretty poor. So that just sucked me in, and I found myself in fellowship where I am right now.
Yeah, that's so awesome that you're so intrigued by congenital heart disease. That's so amazing.
Yeah.
So what are so going into like ways to prevent heart disease? So what are some low cost ways that people can prevent heart disease right now?
Yeah, so there actually, it's the little things that people take for granted, to be honest. Like things like good nutrition, to what you eat every day, that adds up. So we talk about that on the news everywhere. Like you want to definitely stay away from the high caloric foods, the saturated fats, mostly what you find in fast food, and you want to replace those with the healthier options. So high fiber, vegetables, fruits, nuts, and also stay away from red meat and substitute those with healthier options like poultry, fish, just healthier food in general. So nutrition goes a long way because it helps you keep the weight down. And we know that obesity and great weight comes with other issues, diabetes, high blood pressure, high cholesterol, which we'll talk more during the interview. But those are really that's, I think, one of the greatest tools to keep away from heart disease and to just prevent down the road heart disease. And I think even with that, when I talk about low calories food, that also goes along with keeping down the cholesterol. Other things like quitting smoking if you started, and not starting at all is another option. Limiting alcohol, and that's important because a little bit of alcohol is actually cardioprotective. Like if you go to European countries like France, a glass of wine a day at lunchtime, that's very, very typical. So researchers actually show that for women, if you're having a glass of alcohol a day, and for men, 2 glasses of a drink, and that can be further even defined, right? That a day can be cardioprotective. Now, anything beyond that is when you start getting in trouble, because it increases cholesterol and increases your heart blood pressure and all that, all the risk factors that we're trying to stay away from. Now, we don't think about this a lot, but reducing stress is also very important, because when you're stressed, you tend to overeat, right? And that goes along with obesity. If you're stressed, then you make more cortisol, which is a stress hormone, and that also helps you with weight gain and brings up your blood pressure and all those things that we're already talking about. So the question that one would ask is, how do you keep stress down? But then that being an adult it's all about figuring that out. And then along with good nutrition, exercise. Like studies have actually shown that 150 minutes a week of moderate intensity exercise can help you prevent high blood pressure, obesity, and high cholesterol. So that's about 30 minutes a day. It sounds like it's a lot, but it could be anything, like just taking a walk outside for 30 minutes. It goes a long way. And obviously consistency. And a lot of people are doing more, they're being more aware and proactive. And that's why, if you look at everyone, Apple Watches and, Fitbits, or really any device to help you count your steps, right? Because that helps you to keep track of how much exercise you're having per day. So 10,000 steps is what people typically go by, and that's equivalent to that 30 minutes of exercise daily. That is a requirement to stay away from the bad stuff.
Yeah, absolutely. And going more into the nutritional category, like proteins, carbs, and sodium, things like that, how much of relative intake should people have for like specific nutrition categories every single day?
So to be honest with you, I try not to bore my patients with numbers, because people don't really remember numbers. I try to be a little bit more practical. So and I'm going to draw because I'm a visual person, right? So in your plate, so if this were to be your plate right here, your plate of food. So I'm gonna split this up in 3 parts. So this part here should be your proteins. So I would say your meats, the bad stuff, right? The red meats, what we tend to love to actually consume in Western nations. So this little part here should be your meals, should be your protein. This part, this other quarter, or rather, this second half here should be your carbs. So rice, pasta, potatoes, your carbs, and it could be anything you want it to be. And this whole part here should be your veggies, if that makes sense. You can split it into veggies, this half here, and this other half can be fruits. You know what I mean? So I think conceptually, or it makes more sense, or this sticks better, rather than going into numbers. Oh, you want to have a gram of protein or a gram, this makes more sense. And the reason why it's important is because I noticed that most people typically, what they'll do is have carbs. They have more carbs, or maybe proteins. This is usually what you see. There's very little room for veggies. There's very little room for fiber. And that's where people get in trouble. I don't know if that helps.
Yeah, that helps a lot. Thank you so much for that diagram. I know, I know I've seen a couple things like, with like the My Plate. I don't know if you've seen that before. Um,
Yeah.
but like, it's just so interesting to see like, and have it be so practical as well. So yeah, thank you so much for that. And
Yeah.
and I know that you mentioned, keeping track of like physical fitness through like, Fitbits and Apple Watches and things like that. But what are some ways that people can keep track of like maintaining a healthy diet? Are there any apps that you know that may assist patients on staying on track with their diet, or just like the everyday person to keep track of like nutrition?
Yeah, there are actually apps out there. There are actually a ton, ranging from free subscriptions to up to $5, probably even $10 if you look for it. It really depends on what you're trying to achieve, right? Like people who just want to keep track of their diets and who just want to count calories every day or count carbs. I've seen a number of apps. I'm not endorsing any of them, but some of the popular ones are My Fitness Pal. I think that has a free subscription. You have My Net Diary, you have Protein Tracker, Superfood, LifeSum, Fit Jenny, and they all offer based on the kind of subscription that you want. Like you can go with a basic subscription where you're just entering the amount of food that you're eating, and it can give you like a numerical value of how much calories you're having in a day, and that kind of helps you stay in track. Like for the typical person, you don't want to get more than 2,000 calories per day. That is enough for a typical person. So based on how much you're consuming, it tells you where you're at in terms of those goals. And you can even get other apps like LifeSum is an app where you can get a premium subscription, and it tells you, it doesn't only add up your calories, but it kind of factors all of that into the workout that you should get in order to be at a net negative. So say, for example, if on a particular day, I had more carbs than I should, based on my goals, my weight goals, it's able to factor that into how long of a workout I should get that day in order to be net negative, or in order to be aligned with my weight goals. And you can actually get other apps that go a step further in recommending what kind of foods you should be getting, in order to meet that goal. So it's really interesting. There's everything out there for everybody. There's not much of an excuse nowadays not to be aware and not to be proactive to stay healthy. There's so many gadgets out there to help each and every one of us.
Yeah, thank you so much for those recommendations. It's really cool that they're able to factor in physical as well as nutrition, because that's really important to making sure that you're living very healthy. So thank you so
Mhm.
much for that. Um,
Yeah.
so going into like risk factors for heart disease, like what are some examples and how can people address them?
So risk factors for what? Coronary heart disease?
Yes.
Okay. Yeah. So the big bad wolf that we talk about all the time. So high blood pressure, diabetes, high cholesterol, and obesity, right? That's it. It really just boils down to all of those, because and you notice that they kind of tag along. They cohort together. So somebody with diabetes will most likely have high blood pressure, and that's because it stems from obesity, like increased weight. Because when you're obese, there are just physiologic changes that happen in your body that makes you more prone to these conditions. And it all boils down to um, your vessels, your arteries in your body that help you, that help provide nourishment and oxygen to different parts of the body, different parts of the heart, different parts of the brain. And once those once those arteries are compromised in one way or the other, then you start getting this, these conditions like stroke and heart attack.
Okay, yeah, thank you so much. So are there any specific exams that may like diagnose these diseases, like an EKG or stress test?
So yeah, they are. But the way I like to think of it, but if you're doing tests and a workup, you're probably already too late. The key is on prevention, right? And that's where seeing your primary care physician is so important, because when you go for these interviews, they're supposed to get a really good history and do a really good physical exam so that they can identify these risk factors and start addressing them before they're actually causing symptoms. I mean, once you already have high blood pressure and diabetes, I feel like we're already late. Like, we're not doing primary prevention anymore. We're doing secondary prevention. We're trying to prevent the complications. The aim should be at preventing the disease, so you don't even have to worry about the complications anymore. If we're talking about heart disease and stroke, we're already talking about complications. And that's already that's already late, I think. But that being said, things like EKGs can help you identify things like angina. So those are precursors of heart attack. So angina is when you have some blockage in the arteries that supply your heart muscle. Depending on how bad the blockage is, you can have symptoms when you're active. Like you can have some chest pain and some shortness of breath, some dizziness, some lightheadedness when you're active. And that can present on the EKG in various ways. You can have, and sometimes, if the blockage is pretty significant, you can start having those symptoms when you're not even active. So at rest is what they say. You're having angina or symptoms of pre-heart attacks when you're at rest. So the EKG can be very, very, very instrumental in picking up those changes. You can do a stress test, and a stress test is stress test is when they have you running on a treadmill, right? You have a medical stress test too, but those I don't think people like that test a lot. The stress test, which is what I work mostly with, the treadmill stress test. You have them on a treadmill, you have them running for a specific amount of time if they can tolerate it, and you incrementally increase the amount of effort that they're putting. So, and during that time, you're kind of seeing how the heart responds to increased exercise. In somebody who's prone to heart disease, whether it's from blockage in the arteries or to arrhythmias, you're trying to see if they're going to be symptomatic during this test, because you're simulating like exercise pretty much, and you're trying to see how the heart responds. If they get symptomatic during the stress test, then you know for sure that they have heart disease. And then you can start addressing it by medicine, lifestyle, activities, and other whatever you think is appropriate for them.
Yeah, I totally agree with you, like with the part on like prevention. It's really important to like take care of that first and make sure that you don't get to the complication side, right? And
Mm-hmm.
so going off of that, like what signs and symptoms should people look out for maintaining cardiac health?
Okay. So signs and symptoms concerning for heart attack or stroke, is that what you're asking?
Yeah,
Or
like heart attack, stroke, and like general heart health.
okay. So you want to pay close attention to symptoms such as chest discomfort, You know, like I was talking earlier, chest pain while exercising or even at rest. Like typically it will start with exertion, right? Like, oh, when I'm active or when I'm doing something strenuous, I get this chest discomfort. And it can be described, it really varies from person to person, but any chest discomfort or chest tightness is pretty usually described as a pressure on the chest or tightness or squeezing. What I've heard sometimes is like I've heard people say it's like an elephant sitting on my chest. That is concerning, usually in the center of the heart or on the left side of the heart. If it's on the right side, I'm not concerned because the heart is on the left side. Well, some rare individuals have hearts on the right, but that's a different topic on its own. But typically, you know, for the typical person who has the heart located in the left side of the chest, if I have symptoms occurring there or in the center of the chest, I get concerned that there's something going on. Other associated symptoms, shortness of breath, and other even non-cardiac symptoms like sweating, cold breaking, a cold sweat, nausea, lightheadedness, heartburn. And this is really important. These symptoms, these non-specific symptoms are very important, especially in women. Men are more likely to get the typical symptoms that are associated to heart attacks. Women, not so much. Women may come in with the nauseas and the lightheadedness. So you have to keep a low index of suspicion, especially if all these risk factors are already present. If any of the symptoms are associated, and it's better, when in doubt, it's better to sin by excess, if that even makes sense. Like if you're in doubt, it's always better to go to the ER or to go checked out, because I have seen cases where heart attacks were missed because, you know, the patients came in and didn't have the typical chest pain that we like to describe. You know, they came in with heartburn, and, you know, because the physician was not thinking outside the box, you know, they missed the heart, they missed an MI. So, you know, awareness, that's why we're doing this, right? So that you can have more awareness and you know what to do when the symptoms arise.
Yeah, absolutely. And so what sort of symptoms would people see like for a stroke? Because I know there was like the FAST, the fast thing.
Yes.
So
Yeah, so for
I'm sorry, go ahead.
yeah, so yeah, you're right. FAST is an acronym for stroke, easy to remember. And F is for facial drooping. So because what happens in a stroke is you have blockage of the arteries that supply your brain tissue, and the brain tissue is responsible for pretty much everything that we do. So these are symptoms that are very common in patients who have stroke. So the first one is the F for facial droop. So if you notice that there's an asymmetry of the facial feature. So for example, you know, their smile is crooked and they may not be smiling if they're having a stroke, right? But if you notice that one side of the face is kind of drooping as in comparison to the other part, that's what we mean by that. Or if you notice that one eyelid, or, you know, one's asymmetry, and it may be subtle. So you have to have a high index of suspicion as well. A stands for arm weakness. So that's the other part that we talk about. So weakness of one, or it doesn't have to be arm weakness, could be leg weakness too. Like if you notice that just suddenly, you know, they have a gait, they're walking funny, or this sudden weakness of one side of the body versus the other. That's one thing to think about a stroke as well. S is for speech difficulties. So if they're slurring their speech or they're having difficulty speaking, or if you notice even drooling on one side of the face, those are all telltale signs of stroke. And the last part, the T in FAST, stands for time to call 911. Like if you're having any of these symptoms in a patient or in a relative of yours, you need to call 911 and have somebody come in. EMS is faster. It's better to call 911 and have the EMS come in because, you know, even en route to the hospital, they already have some interventions that they can start uh, while on the patient, as opposed to you driving to the hospital. If the hospital is 30 minutes away, that is 30 minutes that the EMS personnel can use to start some life-changing and life-modifying interventions on the patients while they're still heading to the hospital.
Yeah, with that said, like what should one do if they're experiencing cardiac symptoms like the ones that you've mentioned, or the stroke symptoms, or if their family member is?
So to be honest with you, this is an area where I really don't like to mess around. I think the best thing if you're experiencing any of these is to call 911. So try to get them to the ER as soon as possible. Try not to freak out. Try not to waste any more time, because time is of essence. You have to get them to the ER as soon as possible. And in the ER, what you can expect over there is to answer a lot of questions. The physicians are going to ask you questions pertaining to the patient's weight or to the patient's history, medical background, because they may not even be able to answer any of those questions at that time. They may not be responsive. So one thing that I would recommend is to have some kind of folder where you have like a brief medical summary of the medications that you're on, your allergies. That way, you know, the healthcare personnel can get to that really quickly. And once you're in the ER, you know, you can expect them to do quick tests such as an EKG, hook the patient up to a monitor so that they can check the heart rhythm. You can expect them to start the patient on oxygen, give medications like aspirin or nitroglycerin, which really help open the vessels that relieve the symptoms. You can expect them to give, if there is significant pain, to give medication to help with this pain, like morphine. And then depending on what happens to the chest pain, I mean, if it's determined that it's not from the heart, then you may not even get admitted. But if, on the other hand, this is heart related, then most likely they're going to get admitted and get further workup. Within the next 24 hours from admission, they're usually in the cardiac ICU or some ICU setting where they're closely followed up. You know, they want to monitor the heart rhythms and make sure that there's no further deterioration of their symptoms. And then after that, they can determine if they need further workup. Like an angiogram is something that sometimes you need to do, where you're looking closely at the heart arteries. We call them the coronary arteries, and there you're trying to locate the blockage and to also quantify it. Just so you have a better idea of what's going on. And sometimes during this intervention, they can actually go in there and place what we call a catheter to go and actually dissolve that clot. So yeah, that's some of the things that can be done. If the heart disease is so significant, like if there's a very significant blockage of not one artery but several, they may actually require surgery where we do what we call a bypass, and then, you know, just kind of bypass the areas that are diseased and make new connections, if that makes sense, with already existing arteries in the heart or even outside of the heart, just to make sure that, you know, that you kind of help or mitigate that blockage and cause perfusion to the muscle tissue so that you can restore heart function.
Yeah, thank you so much
Does
for
that make any
walking us.
sense?
Yeah, thank you so much for walking us through the process. That was really interesting and important to know as well. So
Yeah.
I know like sometimes people talk about like panic attacks and like heart attacks and like being able to differentiate those symptoms.
Hmm.
Can
Hmm.
you shed some insight on like how someone can tell like, you know, it's whether it's like a panic attack or a heart attack and like what should they do if they're confused in
Yeah.
that situation?
Yeah. Okay, so a panic attack is really just somebody freaking out over anything and everything, and that being kind of exaggerated. And that in a panic, I mean, if you're having, because so in a panic attack, you can, for healthcare workers, it may be, from the history, may be easier to differentiate than the layman person, because during a panic attack, you have respiratory symptoms too, not just heart. You could have chest. Most of the time, you have chest pain too, and the chest pain can be similar to what you see in a heart attack. But there are other symptoms that help you differentiate it. Like, they tend to be hyperventilated, breathing really fast and shallow, and that makes you hyperventilate, and you're not exchanging gas properly, and that can also affect your brain, so that your thinking is a little bit your thinking is affected, and that potentiates the anxiety that you can see with panic attacks. um, a big difference between a heart attack and a panic attack is that the chest pain kind of doesn't get worse or doesn't stay. Once they're able to settle down and kind of break that cycle, the chest pain will go away. In a heart attack, the chest pain doesn't go away because you're having true symptoms that are caused from blockage of that artery. And there is a cascade that is kind of started. That doesn't go away until you do something, and could actually be life-threatening if the patient doesn't get prompt interventions. In a panic attack, they feel like they're dying literally, but it's all psychological, right? The body's not it's not a life-threatening situation, and once they settle down, the chest pain goes away.
Okay.
Does
So
that help?
yeah, because like I know like sometimes like people can be like really confused by the symptoms and it can be like scary, right? Because the symptoms are like so similar.
Yeah,
So would you also recommend like people still like call 911 if they're not sure in like a certain situation? To
absolutely.
okay.
Absolutely, because I mean, you can have a panic attack from heart attack. If you're not able to breathe, and if you're having significant chest pain, and you're not able to breathe, that on its own can cause you to have a panic attack, and can kind of make it's a vicious cycle, and a little bit can potentiate the symptoms of heart attack. Um, and if you have a very, very bad heart attack or panic attack, and you have risk factors for heart disease, you can go into heart attack. So one is not necessarily exclusive of the other. And when you're in doubt, honestly, it's better to get checked by a doctor who can delineate and make that difference, because what we don't want to miss is a heart attack in whatever circumstances. So I would rather have you go and get checked in the ER, and they can triage you appropriately, and they're able to tell over there if you're having a heart attack or not, rather than staying home and it turns out that you truly are having a heart attack and it's not addressed properly. That has more deleterious outcomes, that I would rather not have to deal with as a physician. I would rather see you in the ER and make that decision for myself.
Okay. So with that said, I mean, from our previous conversation about like walking through like what happens like during a heart attack. So what happens like after the heart attack and like, you know, they receive care for it?
Mm-hmm. So after you're outside of the red window, and you know it's important to get the symptoms controlled. And typically while you're in the hospital, we take care of that. We help with reperfusion, dissolve the clot. Now, the important thing is to make sure that you don't get a recurrent event, because recurrent events lead to worse outcomes. And usually what happens is, if you've had a true heart attack, the tissue is dead, the heart tissue is dead. So you're having some complications from that. So it's really, really important at that point to have very close follow-up with your physician, your primary care doctor, and your cardiologist, to make sure that you're really you're actively participating in those in modification interventions that will prevent further deterioration of the disease. They may put you on medication to decrease your blood pressure, or to control your diabetes, or to control your cholesterol. Those are all medications that you'll probably be put on. So you have to be very compliant to those, and you have to be more tuned to your body, so that if you're having any symptoms, whether it's from the medication, or it's from or it's from a recurrence, you're being proactive, so that you're getting prompt and timely interventions to prevent further complications down the road. I've seen, this is not something that I have a lot of experience with. It's more of an adult thing, but there's cardiac rehab that some patients go to, and that's just to help them, because you can get some deconditioning, from prolonged hospitalizations, or from just, like I said, dead heart tissue, as a complication of this. So cardiac rehab is to help you get back in shape, help your heart to get conditioned, to get back in shape. It's kind of like a tune-up, if that makes sense. So that's something too that your physician may recommend to you. And then obviously you have your routine EKG, stress tests, every so often, as dictated by your physician, to just kind of see where you are in the disease process, if you're making some progress, or if you need more tuning up. So it's really, really important to maintain follow-up with your physicians after this happens.
Yeah, thank you so much for shedding more insight onto that. I know it can be kind of a scary thing for a lot of people, but it's really important for them to stay in tune with their body and understand these signs and symptoms and, the consequences. So, and also another heart condition.
Yeah.
So going into like cardiac arrest, can you explain a little bit more like what it is, what causes it, and people who are at risk?
Yeah. So cardiac arrest is cardiac arrest is different from heart attack, and I think a lot of people confuse the two. A heart attack can lead to cardiac arrest, but cardiac arrest is different from heart attack. So cardiac arrest is the sudden loss of function of the heart. So the main purpose of the heart is to pump blood to the body, and the body is the brain, the heart itself, the heart pumps blood even to itself, and to muscles, and the stomach, everything, because you have oxygen in blood and you have nutrients, which body parts need to function normally. So that is predominantly what the heart does, and that is essential, is vital to life. So cardiac arrest is that loss or that inability of the heart to do that. And it could happen in somebody who has heart disease versus somebody who's completely healthy, right? Risk factors, like you said, can be, I mean, it varies. The most common factor that we see, especially in the pediatric population, is arrhythmias. So, if there is a derangement of the electrical conduction system of the heart. So before the heart knows to pump, there is an electrical signal that comes in. And that's also what helps in the synchrony of the heart pumping, because there are four chambers altogether. You have the atria, and then you have the ventricles, right? The atria are the collecting chambers. They receive blood, they collect blood, and they contract first. Now, when they contract, they send the blood to the ventricles, and the ventricles are what we call the pumping chambers. So if there is asynchrony and the ventricle is contracting before the atrium, or the atrium is not conducting in a fashion that is leading to that synchronous flow in the heart, you can get cardiac arrest from that. And that's what we call an arrhythmia. Not to get more detail and bore you with the details, you can have different things. Like VFib is one of the common ones that you hear about. You hear about VTAC sometimes. And just to give you some context, VFib, your heart should be doing this. Your ventricles should be doing it when it's pumping blood. But in VFib, you have like quivering. So you're not having that organized system where the blood is pumped out. You're just doing this, and the blood is not really doing anything. It's just sitting there. That is very dangerous, because the blood is not going out to the body. Or you can just have the heart not pumping. It's just not pumping quick enough. So those are some of the things that can happen. You can have scarring of the tissue, and that's very common in the pediatric population. Kids who are coming in with congenital heart disease and who need surgery. After the surgery, it's not uncommon to have arrhythmias, because during the surgery, you're messing with that muscle and you're messing with that conduction system. So it's very, very common to have arrhythmias after heart surgery. And we see that commonly in our kids. You can have cardiac arrest from thick heart muscle. Actually, the most common cause of cardiac arrest in adolescents is hypertrophic for thickened cardiomyopathy. So you're having thick muscle, and that can just be genetic. They're just predisposed to have thick muscles. And sometimes if the muscle is too thick, it can actually obstruct the blood from going out of the heart to the body. So that's something that can happen too. So even in the absence, you can have a diseased heart. There are genetic conditions that predispose some individuals to just having arrhythmias. Like they talk about long QT syndrome. That's something that can run in families. And if you have that, you're more predisposed to cardiac arrest because of that. And something else that can lead to it is recreational drug use. Like some of these drugs, we don't know everything we don't know all the side effects, but cardiac arrest can be one of them. Cocaine can actually cause heart attack, and your heart can arrest from that. So like this is something that you definitely want to know when you go into those situations. That's something that you should keep in the back of your mind, that you can arrest from some of these drugs. Yeah.
Absolutely. Thank you so much for shedding more insight on like the connection between like cardiac arrest, arrhythmias, and like other causative factors. So going into like how can one determine if someone is in cardiac arrest, and like what should they do if they're in that situation? Because like I know a lot of times people talk about like giving CPR and things like that, but like you shed more insight on like how people should do it and like when.
Yeah, absolutely. So not many things, not there are not many things that you need to remember when someone is in cardiac arrest. Like I said, you don't have blood is not leaving, blood is not getting pumped to the body, and one of the first places to get affected is the brain. And if the brain is not getting oxygen, then they go into loss of consciousness, they become unresponsive. So that is one of the quick ways that you know that, oh, okay, there may be something wrong with the heart. Also, they could be cessation of breathing. You know, they're not breathing, or they're breathing funny. So that's one of the two things, because they in some of the algorithms for CPR, like in the lectures and in training programs, they specify that it's not just the absence of breathing. Like if you look at them, they may be gasping actually. And the fact that they're gasping should cue you into the fact that you may be dealing with cardiac arrest, because even though they're doing something, they're gasping, it's not a true breathing pattern. Like they're not exchanging oxygen. So that's when you should definitely red flags, red flags. And immediate, because time is of essence. If your heart is not pumping blood, you don't have a lot of time. So you have to activate some kind of system to address this. If you're alone, and this happens, like you could be a bystander or a passerby passing by, and somebody just drops, it doesn't warn you. Cardiac arrest is not going to warn you. It can happen suddenly without any warning. So you know, you're the person on the scene, you want to cry for help right away. You may be alone. In that case, then you just need to check for pulse and check if they're breathing. If there's no pulse, and pulse, to check for pulse, you know, just put your hand on the neck area here on the side. Typically you can feel a pulse there. You have the carotid pulse there. You feel some throbbing. If you don't feel that, don't spend a lot of time trying to figure that out. I would say do spend maximum 10 to 15 seconds. If you don't feel something there, then just start CPR. Just start CPR. If there's someone that you can call for help, then that's perfect. Then call for help, have them call 911, or have them locate an AED, an automated external defibrillator, and get started on CPR. Get started. So the way you do CPR, you just have your hands like that in the center. Let me stand. So, because it's important, right? So here in the center of the chest, you want to have your heart here, and you want to push. You want to push hard, and you want to push fast, okay? The reason why it's important to push hard is because, think about it, the heart is right here underneath, and you want to be able to reach it. If you're just doing little shallow things, you're not really reaching the heart, and you're not pressing. So you're manually pumping blood, if that makes sense, because the pump is not working. So you are manually pushing blood out of the heart to the rest of the body. So the effort has to be deep enough. Typically 2 inches down into the chest area is what they recommend. And I would not be scared to crack a rib or something. I would rather crack a rib and help them breathe and live. And then later on, you can think you can address the crack ribs, then not provide enough CPR, if that makes sense. So you want to push hard, and you want to push fast. So typically 100 to 120 pushes per minute. And the recommendation, if there's someone there with you, after 2 minutes, you guys should switch, because effective CPR is tiring. After 2 minutes, you should probably switch, because you'll probably be getting tired if you're doing it properly. But yeah, that's how you provide CPR, and it's very, very important to do it efficaciously, so that you can save lives. Yeah.
Yeah, I mean, I have like a couple questions on that, because I know like sometimes people like there's like the 30 to 2 breaths thing. So should people like also normally administer like breaths too, or is that not something that people should do?
So it really, it depends. If they're breathing, if there is no pulse and there's no breathing, then you definitely want to do the 30 to 2 in adults. So it differs, right? Because, and that's that's where it becomes really confusing for the provider, right? Because for neonates, it's different. For pediatric kids, it's different, and for adults, it's different. So in adults, you're doing 30 compressions to 2 breaths. So somebody is pushing, you do 30 compressions, and then you provide 2 breaths, and then you go back and you do 30. That is if you're by yourself or with 2 people. It really doesn't matter. The 30 to 2 is for adults. For children, it's 16 to 2. The reason why you're doing 16 compressions and 2 breaths is because kids are, like, the most common cause of cardiac arrest in kids is respiratory compromise. So they need more breaths than compression. And if you're actually providing good ventilation or exchange, if you're providing more breaths, how do I say this? They need more ventilation than cardiac support, if that makes sense. So if you're providing effective ventilation, most of the time you can get the heart to respond properly. It's not the same thing in adults. Adults are more cardiac. Arrest in adults is more cardiac driven than respiratory. So they need more of the cardiac, they need more compressions than kids do. So that's more of the rationale behind it. So in kids, you would do 16 compressions and then you give 2 breaths and vice versa. In the little kids, it's even more different. In the neonates, you're giving, I think I'm blanking in the little kids, but the little kids, most likely that's not gonna happen. The CPR is different in so many ways. The way you're providing it, the pulses that you're feeling, but even in that case, you're giving more breaths than compressions.
Okay, yeah. So just to recap for like everyone, I just want to like make sure we get this right, right? So the way we interlock our hands is like this or this, right? Is that right? I just want to like double check.
Wait, say that again?
Like the way you like interlock your hands like in it, like how would you like?
So it's really any position that is going to provide adequate effort, compression. So people do this and then they're compressing with the bottom part. Don't get caught up on how to hold your hand. Just make sure that you're providing enough effort, like enough strength in your compressions. Okay? And some people do this.
Okay. Yeah, I know. It's like really something that we should be looking out for, but like for sure. Like I feel like people should definitely follow like the 30 to 2 or like 16 or did you say 16?
16 to 2. Okay. So most of the time, this is probably what you're going to need to do. 16 to 2 and 30, 16 to 2 in kids who are, majority of kids up to about 6, I would say outside of the newborn period, so 2 months and above, you would do the 16 to 2. This is for the big children, so 6 months and above, sorry. And adults, really anyone from 9 years and up, you do the 30 to 2.
Okay. Got it. Yeah. Thank you so much for that. I know it's such an important skill that people should learn as well, just to, provide life-saving interventions. So yeah, thank you so much for giving a little bit more insight on that. So regarding like the treatment protocol for cardiac arrest, like how are infants and young children treated when experiencing a cardiac arrest, and like how does cardiac rehab assist patients who've gone through like multiple surgeries?
Yeah. Sorry, I just wanted to clarify real quick
Yeah.
for infants. Yeah, for infants and children. Yeah, so in the little babies, you are doing, in the newborn, you're doing 3 to 1. So 3 compressions to 1 ventilation, to 1 breath. And in the children, so 1 year and up, or sorry, a few months and up, that's when you're doing the 15 to 2. I just wanted to make sure that I was providing the right information.
Yeah, absolutely. So like what kind of, because I know like once they're like, given cardiac, sorry, CPR, and then the EMS arrives, like kind of like, can you walk us through like kind of what happens from like after that, like, going into advanced life support and things like that?
Yeah. So when the whole purpose for uh, advanced life support is to restore cardiac activity, to get the heart to pump on its own. And typically, and that's why there's an algorithm that you follow that. Most of the time, fortunately, especially in kids who are very resilient, we're able to achieve that. And after that, we're trying to address what caused the cardiac arrest. So if it was maybe some electrolyte derangement, like electrolytes are out of whack, then we try to correct that. If it was an illness of some sort, like myocarditis, then you try to provide support to the heart, because sometimes you can't really do you can't really treat it, um, and that's in the sense where we're talking about illness that's maybe caused by a virus, like viral myocarditis. That's commonly the cause of heart disease in the little ones. You can't really stop the viral infection. It just kind of runs its course, but there is diminished function from that infection. So you support the heart until it completely recovers, and then you send them home. So, the emphasis at that point is to give the heart the much needed support that it needs, and correct, or at least wait for the injuries that caused the arrest in the first place to kind of pass, so that they're in a safe place where you can send them home, and just have them continue to be convalescent in, if that even makes sense. I know you talked about rehab. There are different things. There are different things that they can do. You see you see if they have any kind of buffer, if they have any reserve, and you address that. And you want to build that reserve as much as possible. So a kid who comes to rehab, for example, and you have them on the treadmill, if they're having symptoms after 2 minutes, you know that they have no reserve. They have no reserve whatsoever. So the cardiac rehab focuses on interventions to help them to get back to where they are, so that they can have some kind of reserve, so that if they're sick again in the future, then they have a buffer. And that may not always be possible, but they have a lot of experience, and they have a lot of interventions that they try to get them as much as possible back to recovery, and to get them back to baseline.
Yeah, thank you so much for that. I know it's a lot of content already, but there was a couple questions that like we wanted to ask about like risks of like infant or young child experiencing like cardiovascular disorders, and like should they be concerned about heart health as well, like young kids and infant kind of range?
These are very good questions. So now the adult and the pediatric world tend to be very different with cardiology. The things that pediatric cardiologists worry about they may overlap sometimes, but sometimes they're really separate entities. So cardiac arrest in little kids, like I said, arrhythmia, and a big thing that I didn't mention is congenital heart disease. Congenital heart disease, I think, is definitely what separates a pediatric cardiologist from an adult cardiologist, because they have patients with congenital heart disease have their separate set of issues that need to be addressed sometimes sooner than later, and that continually through the rest of their lives will have to be addressed as well. That being said, the infants, babies who are born with critical heart disease, congenital heart disease, are usually the babies who will have some form of cyanosis, or that's a big word. Those are the kids who are born with the inability to carry oxygen in their blood, if that makes sense. So those are the babies that tend to be blue, because when they get oxygen from the heart, so the blood goes from the heart to the lungs, where it picks up oxygen, to be more specific. So blood comes into the right side of the heart and it's pumped to the lungs. And then from the lungs, it's pumped to the left side of the heart. And from the left side, it's pumped to the rest of the body. Okay? So those are two main functions that a heart has to be able to perform. If one of these duties are affected, then you have congenital heart disease. And that can be from different things that go wrong with the anatomy of the heart. So that as a whole is congenital heart disease. And ideally, you want to be able to diagnose this when the baby is, you want to be able to diagnose this in utero. So when the baby is still in the mom's uterus, because when they're in the uterus, they're protected. The physiology of the fetus allows it to thrive, even in the midst of these congenital defects. Once they're born, things change, the physiology changes, and they become symptomatic. So the reason why, as a pediatric cardiologist, I want to be able to diagnose this prenatally is so that when mom delivers, there's already a plan in place. You know, there's interventions that need to be done right away to kind of mitigate and to palliate these symptoms from happening. Because once these symptoms start happening, there is end organ damage, and sometimes it can be irreversible. Quality of life can be severely affected for this baby. Whereas if I address this before the baby even becomes symptomatic, then there's a huge difference and outcomes are way better. So that being said, you know, there are signs, there are things that we check for in every single baby. And this, you know, is dependent, it is state to state dependent, but most states have established critical newborn screening for all babies. And one of these is the critical congenital heart screen. So every baby before getting discharged have to pass this test. If they don't pass, then I have to do an echo. An echogram is just a test that takes pictures of the heart to see how it's functioning and to see how it's formed. So if this test that I'm talking, this screening test is not positive, or they don't pass the test, then I need to have an explanation as to why that is. Sometimes all it takes is just rule out congenital heart disease and then just figure out what's going on down the road. But that's one way that we pick these. That's actually one of the main ways I would pick these up if they're not diagnosed prenatally. Another thing that you want to worry about in the little babies is something that we call sudden infant death syndrome, SIDS. While the literature says that we don't know for sure what causes it. There are some theories that congenital heart disease may actually contribute to a small portion of these kids. If there's a specific subset um, of congenital heart disease that predisposes them to arrhythmias. And some of these babies can just die during their sleep because there are some abnormalities in the defects of their conduction heart system, and they're not able to pump blood as they should, and they just die. So it's rare, but once again, these are risk factors that you screen for. So every child that comes, you want to ask how they're, you want to assess for those risk factors. And that is up to the pediatrician or even the pediatric cardiologist. They're able to pick and fine tune some of these things in the history that makes them want to dig deeper and rule out these conditions. Did I answer your question?
A lot more sense. Yeah, absolutely. Yeah. So, I mean, yeah, it's definitely good that there's a lot of screenings put in place for young children and infants, to keep track of these conditions as well. So thank you for elaborating on that. And our last question for today, what kind of screening measures are given for heart health commonly, and how often should people have them?
So routinely, I honestly don't think that it should be such a thing as a routine heart screen test because, they tend to be really expensive and they may not be that sensitive or specific for heart disease. But I will emphasize that a very good history and a physical exam most of the time will help you pick out patients with risk factors who then you can decide if will need further screening of some sort. So that's why, again, the role of the primary care physician is so crucial in this because they are the ones who spend more time with you, with the patients. They are the ones who ask all those important questions, and they're the first line in your medical workup. They're the ones that you will go to if you have a chest pain or if you have anything that is suspicious of heart disease. So that's why it's so important to have routine follow-up with your primary care physician and to adhere to the screening protocols that they put in place for you. That being said, if they go through that and, there's a suspicion or there's a concern, then the basic workup typically starts with an EKG. You start with an EKG, it's relatively cheaper than the other things that you get to do, and you can pick up some subtle things, like I said, things like ST elevations, which can be suspicious for angina or, even irreversible changes that are precursors for heart attacks can be picked up. And you have little subtle things too, like signs of, it can demonstrate findings for ischemia, like angina, like I said. Those things can be picked up on EKG. For little kids like us, our patients don't really have heart attacks. It's not very common in the pediatric population, except in some very occasional cases, like specific cases. But even with the EKG, you're able to pick up signs of arrhythmias. Like we talk about prolonged QT, we talk about prolonged QRS. Those things are very, very, very important and can be picked up on EKGs. The important thing to remember, however, is that the EKG will not always pick them, even if they're present, because the EKG is only 60 seconds. It's just a 60-second snapshot in time. So if that finding is not captured on the EKG because of that time frame, it doesn't mean that it's not there, and it actually could be missed. The other thing too is that the EKG is very the EKG can pick up a lot of things that are not clinically relevant, right? So like we tend to say, it's overly sensitive. Like it picks up too many things, which are not necessarily concerning. Let me give an example. Left ventricular hypertrophy. So a portion of the heart being thickened, which you can see in high blood pressure, can be picked up on EKG, and will make you do an echo. And when you do the echo, that finding isn't present. So that's why there's also a concern in overperforming a test, because you may catch a lot of false positive things, which lead to additional workup that is expensive and unnecessary. So that's one thing that you definitely want to keep in mind when you start doing all these things. And that's why it goes back to having a really good history and a really good physical. Like if none of these things, like if I'm not having any red flags, then there's no need for me to do an EKG, because then I may catch something on EKG and I'm stuck with that. I have to do further testing, which may end up being unnecessary.
Okay, well, thank you so much for sharing your knowledge today. We really appreciate all of your help. Yeah, and thank you so much for all your information.
Well, thank you for having me. I hope I didn't bore you with all these details. I tried to simplify it, but I also wanted to explain it in a way that made sense. That way, I'm not just shoving information down your throat, but I'm giving some context with it. I
Yeah,
hope that helped.
yeah, you were very thorough and everything was like really well explained. I feel like our audience is definitely going to get a larger perspective on like cardiac issues. So thank you so much again.
Thank you.